You're listening to the Sick and Good podcast. My name is Dustin Messick. I'm a registered dietitian nutritionist and a cancer survivor.
My name is Colin Goodwin. I'm a clinical psychologist and a cancer survivor.
In 2024, we are highlighting the Cancer Awareness Month in a special series.
We're promoting wellness by having discussions on screening, treatment, and recovery throughout the cancer journey.
To find a balance between sick and good.
That during the cancer process, both can be true.
The Sick and Good podcast is for educational purposes only. The podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition or treatment and before undertaking a new healthcare regimen.
April is Testicular Cancer Awareness Month. And speaking to this topic, we have the founder of the Testicular Cancer Society, Mike Craycraft. Mike is a registered clinical pharmacist and testicular cancer survivor. And he's involved in research and advocacy of testicular cancer. Welcome, Mike.
Hey, welcome. Thanks for having me.
I wanted to then just ask, how has your specific diagnosis impacted your work?
It pretty much flipped it upside down, I would say. Previous to my diagnosis, mainly my entire career was spent in medical centers, working in management. At the time of the diagnosis, doing a lot of facility-wide clinical care work, cardiovascular disease, the cath lab, and open heart program, infectious disease programs. And then it completely shifted where my diagnosis, at first, I didn't really advocate for myself. Then I jumped in with both feet and basically switched to throwing all my efforts into learning more about testicular cancer and kind of putting pharmacy on the back burner.
Interesting. Pharmacy going on the back burn.
It's a great career to have if you need it to make some money, but otherwise really didn't focus on it too much going forward. About a month after I was diagnosed, I was laid off in middle management, or a month after I came back from medical leave. Really couldn't figure out what I wanted to do. Do I want to go back into management or just be a regular pharmacist where I have to work weekends? That's when I see my friends. And so there was a big debate there. Worked about a year just doing overnight because I would get a week off to see friends, and then really shifted it all. There's one point, about 5 or 6 years, I didn't practice pharmacy whatsoever. I think I went back per diem. So it's a great career to fall back on if you need it.
Yeah, those weekends are important. I am really curious, what inspired you to create the Testicular Cancer Society?
It really was a need, to be quite honest. So when I was diagnosed, and this was 2006 is when I was diagnosed, but what I found is there weren't very many resources available for testicular cancer. And what resources were available were hard to find. The advent of all the internet discussion groups and everything else. And so you would find a group for testicular cancer and see that there was 8 people ever joined it. And the last person was a year ago that actually had a conversation. And so there were other resources available. There was a listserv from the Testicular Cancer Resource Center that was great. There were forums at tccancer.com that were great. And so I thought if we could serve as the hub of a wheel, and if people found us, we could show them where the resources were. And then more importantly, with my medical background and survivor experience, could we find out from those survivors what else they need and didn't have, and then go ahead and create those solutions for them moving forward?
Sounds to me like you probably gave up your weekends.
Sometimes I gave up pretty much any hour of the day that someone needed anything.
Yeah.
Mike, can you tell us more about the forums that are offered through the Testicular Cancer Society?
Yeah, so they were created well before my diagnosis and really were a resource globally for people affected by the disease. And all sorts of people obviously are diagnosed, but there was a ton of real life knowledge on there. You know, you're going into chemotherapy, you have questions. 12 guys would respond saying about day 10 to 12 is when I was losing my hair for my primary chemotherapy. So that real life experience was incredibly important. And I don't know, it's probably 8 years ago now. And there was a threat of them shutting down. So we ended up taking over the forums and making sure really hadn't changed anything whatsoever. Just wanted to make sure that they were preserved for the next guy diagnosed or the next caregiver that needed help and move forward. So they're really the world's largest forums on testicular cancer. The volumes have dropped as technology has changed over the years and people search for answers elsewhere, but still just the repository itself of knowledge and the help you receive from it is pretty incredible.
And Mike, can you speak to your involvement in the Malignant Germ Cell Cancer Consortium?
Yeah, so 2 years ago, I was accepted into the Malignant Germ Cell International Consortium. It's really a group of just over about 100 germ cell experts worldwide. And really, the vast majority of testis cancers are germ cell tumors. So it was a good fit. And really, I came in as a patient advocate as well. And so what's really important to MAGIC is what we call it, is having that patient advocacy part to it. So as far as new clinical trials that we're developing now, what's important to the patients? And it's sometimes researchers might not understand the side of, hey, this treatment's great, but financial toxicity. So if there's a 2% difference in outcomes between, I'm just making that number up, but between, say, 2 or 3 cycles of high dose chemotherapy, where you're losing 3 to 4 weeks of your time, is that financial toxicity of not being able to work and having no income really worth it to the patient for an extra 2 or 3% chance of success? Those are a hypothetical question, but an important question to answer that maybe the researchers themselves aren't thinking about.
Yeah, and stress is also such a factor with like how well you do, I think, with treatment. If you're like super duper stressed because you're not going to pay this month's mortgage, I think that goes into, should be taken into consideration.
Yeah, looking at patient reported outcomes, a lot of the measuring tools that are used as far as quality of life have been difficult to discern kind of how testicular cancer affects patients. We see it. We see it quite a bit, but the issue is the tools really aren't measuring. Like the hospital depression scale doesn't really apply to testicular cancer patients too much. You don't see any difference in results. But take example from another aspect. Anecdotally, we noticed that a lot of patients mention having hot flashes and night sweats. Okay. There's no symptoms of testicular cancer when you're looking at them on any website anywhere that mention this. We were able to take that kind of anecdotal knowledge and part of the research we've done, actually able to show that hot flashes were a sign of later stage diagnosis. And so that's really where the patient advocacy is when you're talking to patients from all around the world and even the top testicular cancer institutions, and those are consolidated, may see 400 or 500 patients a year. We're talking to 1,000 or more, probably a couple of thousand. So sometimes you can learn from the patient side of things that you don't really recognize in the basic research.
Yeah, I actually also have a cancer survivor from germ cell cancer. And I think if it wasn't for the family support, and I was so young, I think the stress that treatment can take a toll on anybody, because I also did high dose, but financial constraints would probably affected my outcome a lot more. So I'm glad that medical providers like yourself are taking some of these things into consideration.
Yeah, it's important. I also think from the patient perspective is what's important for their outcomes. A lot of times in clinical trials, obviously, we're looking at adverse effects and how we rate them on the scale of minor to major kind of impact. And those are obviously incredibly important. But there's also the patient side of it where patient might not really care what their risk of pulmonary embolism is. They want a PICC line for easy blood access. It's a weird dichotomy, I suppose, on what's important to the patient and what's important for the best outcome. And where can you find the balance in between for that individual patient?
Yeah, I actually also had a pulmonary blood clot during my treatment, and just something that kind of happens sometimes when you're doing chemo, apparently.
And that's with germ cell tumors, there's a higher rate of thrombotic disease that occurs. And what we see now is it really is more related to, there are some disease aspects, but the use of PICC lines and also ports. And now most patients, you ask in a forum type situation, should I get a PICC or a port? You're going to have a lot of people say, I like my PICC, and a lot of people say, I like my port. It's great. You don't have to get stuck as much as far as blood draws and chemo administration. And in a case of high dose chemotherapy, you're not really going to have an option. But in case of primary chemotherapy for testis cancer, the major thought leaders and institutions around the world avoid PICC lines and port as much as possible. These are usually younger patients that have good venous access. And these venous access devices actually are what causes the initial clots and then moves to the lungs and has a potential to be fatal. There's where the balance is. The patient preference there, yeah, is important, but being able to come back and say, the question, it shouldn't be a PICC or a port. The question should be, can we just do it with peripheral access?
That's so interesting. I did not know that. I actually had a PICC and a port, PICC during my aggressive chemo and a port during my high dose chemo. And I'd say that the port's great, but if you're not doing high dose, like it's just a pain to have that plugged into you. I had all these t-shirts that when I had the port where I would cut a hole in it, because you've seen ports, they've got like the tubes that come down from. Yeah. So I remember I had like probably 20 different shirts during that time that had a big hole in it.
Just for easy access, right?
Yeah, easy access. Yeah, these were my port shirts. But then you get the port off and you're like, all right, now I've got these huge rips in my shirts.
Yeah, you're laying there for hours getting your chemo, and the other option is you're going shirtless and have a gown open. It's a lot nicer to be covered up and warm, and there's a little circle there you can access my port.
Yeah, maybe some cancer foundation will come up with some port shirts as like a support.
We've actually seen some over the years.
Yeah.
I think the original one I saw, I'm like, you're wanting $50-some for a shirt. Like, this is basically mostly adolescent and young adults, and they're going through chemo. Like, they don't really have, or you're asking them to pay.
A little bit of a disconnect there, right?
Just cut a hole in it.
Yeah, I could see that. If you lived in a very cold place, you could have like port jacket. That'd be like, I think you might want to pay for that.
I think I had a Hickman catheter, and what I would do is have an undershirt and then a little clip that I would clip I don't know if there's a term for the nodules, but then just bring them up so they wouldn't be dangling or caught on something. So it's, I guess, a different kind of then way of having to deal with the maintenance to then have a central line.
Yeah, and it comes down to the treatments, right? There's treatments where you're not going to have the option. You're going to need a port or a PICC or Hickman or whatever. But in the larger majority of testicular cancer patients in the primary treatment, you can get by with peripheral access. The other issue is when it comes down to what's just the individual physician's experience with testicular cancer. A lot of doctors may only see a handful of testicular cancer patients their whole career rather. And their knee-jerk reaction in the office is patient, cancer, chemo, PICC or port. And they're not really critically thinking that this is a 35-year-old, otherwise healthy individual, not the average 76-year-old. And I think just being able to bring attention to it, where you can say to the patient, hey, did you talk to your doctor? Do you need this PICC line? Can they do peripheral access? And could it be real cool, like back in the day where they actually let you sneak out with it so you're not getting stuck 5 days a week? There's certain aspects to help overcome that.
We're on this topic. Could you explain to our listeners? So there's the PICC, there's the central access, and then there's the peripheral access. What is that exactly, the peripheral access?
So the peripheral access is basically access further down in the cardiovascular system. So your central venous access, which occurs with a port, which is called peripherally inserted central venous catheter, actually ends up in the big vessels close to the center of the body, to oversimplify it. Peripheral access is typically what those patients get when they go in and get an IV, where you're just stuck in the lower aspect of the arm between the elbow and wrist and administered medications or intravenous fluids via that.
Yeah, actually, one time when I was in the hospital, they tried a lot of picks and they, for some reason, would like not work out. And one of the doctors was like, if we can't find a place to just put the IV in, we'll just put it in your foot. And I don't know if that was a joke, but I remember being really freaked out about them putting an IV in my foot.
Wait until they mention osseous access. So that's where they actually can infuse intravenous fluids into your bone. That's done a lot of times in young babies, but even in trauma situations, you can put an osseous line into someone's shoulder and administer fluids, which, if you see a video of it, is mind blowing.
Yeah, it sounds fun.
Yeah.
Yeah. Wow. That sounds insane. It reminds me, I actually had a spinal tap a couple times and I'm like, that was terrible. So imagining people getting these, can you do chemo like that? Like into the bone like that?
To be quite honest, I'm not necessarily sure. A lot of times it's more emergency cases. So I can tell you what, if I'm in a traumatic car accident and you can't find a vein to start an IV line and I need it, I have no problems with you going into my bone. It's not as painful as it sounds.
Okay. Yeah. And next time I'm in a car accident, if I hear the medical providers talking about it, just put it in the bone. I'm cool.
I like that you said the next time you're in an accident.
You probably won't hear it either. So that's the other important thing. Hey, do whatever you need if I'm not responding and you need something.
Okay. I'll remember that. Do whatever you need. And now just switching gears a little bit, could you tell us about your peer review American Urological Association guidelines?
Yeah, so in 2019, the American Urological Association came out with guidelines for early stage testis cancer. They really didn't go into the more advanced stages of chemotherapy and that kind of thing. But I had the honor of being invited to review the guidelines before publication and really be able to provide some input. It was a pretty huge honor in the fact that there were only, I think, maybe 3 of non-physicians in the world that got credit for being one of the reviewers. But it also, again, gave that not just my pharmacy career ended, I threw myself all into testicular cancer. I used to say there's not an article printed that has anything to do with testicular cancer that I haven't already read. So it enabled me to use that knowledge, but then also from the patient perspective. We know that there's issues of hypogonadism or low testosterone after testicular cancer diagnosis, especially in patients that receive cisplatin-based chemotherapy. I could mention, hey, you never really mention anything about addressing hypogonadism. And this is the American Urological Association. This is something you deal with in practice. Or, hey, there's no mention of measuring it at baseline. And so one, it was a huge honor. And 2, hopefully my critique of it before publication helped in some little ways.
Can you tell us about your research on testicular self-examination?
Yeah, this is something that we started quite a few years ago. I was actually walking around a pool in circles one day. And so the issue comes down to the United States Preventive Services Task Force has recommendations on if you should do a self-exam or if testicular self-exam should be done, just regular medical checkups. And what was interesting, in 1996, their recommendation level was a C, as in cat. And basically what that means is that the possible harms of checking yourself versus the benefits of checking yourself were too close to really make a recommendation. So it just is one of those, I don't know. Do it, don't do it. It should be fine. 8 years later, they came back and rated it a D, as in don't do it. And the review basically said there's been no new evidence, but we're changing our recommendation, which didn't make a lot of sense. There's a difference between a lack of evidence of benefit or there is evidence of lack of benefit. And it's a little nuanced, but there was a study or a literature review quite a few years ago. I think it was printed in BMJ, and what they found that there was no randomized prospective clinical trials on the use of a parachute to prevent gravitational injury. So there is no evidence that a parachute will help you keep from injured if you fall from the sky. But it made sense to me that if I'm jumping out of a plane, I'm going to want a parachute, even though I can't find evidence that I should use it. And so that really got me to thinking, like, how can we reverse engineer this, so to speak? There's never going to be a prospective trial of tracking, I don't even know how much to find clinical significance, hundreds of thousands of guys. And if they do a self-exam over their entire life, and if they find testicular cancer, is it going to reduce the risk of death that they check themselves? So we decided to go to the survivors themselves and see if we could find any data in there. And so we had a database of close to 700 survivors. And we published a paper in 2022 in the Journal of Adolescence and Young Adult Oncology. And it really was the first paper to show evidence that testicular self-examination is correlated or is related to earlier stage diagnosis. So it's not perfect data, but it really gave us the ability to say, hey, here's a piece of information we found that no one else has really looked at. And we did it by reverse engineering.
Yeah, it sounds like there was like a type 2 error before where there was a kind of like that false negative, or that they weren't able to then say that these self-examinations really did any good. But within returning to that, and you were able to then determine that it does make a difference in that early detection.
Yeah. And again, it came to logic. There's data out there when you dig through the studies that you can show that patients' primary tumor size, so the tumor in their testicle originally, the difference between a 2 centimeter tumor, or let's say a 2 to 4 centimeter tumor, to a 4 to 6 centimeter tumor, to a greater than 6 centimeter tumor, the 2 to 4, which is smaller, versus greater than 6, the greater than 6 has a higher likelihood of stage 3 diagnosis and a higher likelihood of mortality. If you're a patient, how do you tell the difference so that you're not having a tumor greater than 6 centimeters? It makes logical sense is that you're checking yourself regularly and you find it when it's 2 centimeters. So it's not a prospective trial just for that purpose, but there's data out there showing that logically it makes sense. One of the recommendations, or one of the reasons that the United States Preventive Services Task Force said don't do a self-exam is because if you find something and it's not testicular cancer, it could cause anxiety. That's weird because I would look at data from, I don't know if everyone's familiar with low-dose CT, chest CT imaging for lifelong smokers. And what they found is when they did these screenings and they found a lesion in the lung of a lifelong smoker and told them, hey, there's a lesion, but it was a false positive. They didn't really have lung cancer. These individuals didn't have any health-related quality of life decreases. To me, it made sense is that a young guy feels a lump. How more anxious is he going to be to have an ultrasound and find out it's nothing than a lifelong smoker to have a lung lesion, find out it's nothing? So again, this was anecdotal that they just said, and the experts say it could cause anxiety. Let's take a better look at this. And we've argued that as well in a recent paper in 2022 in the American Journal of Men's Health, calling for the USPS to re-examine their recommendations. According to them, they should re-examine their recommendations every 5 years, and it's been 12 years since they looked at it, and that was 2022. So hopefully at some point it won't fall upon deaf ears and they can relook at it. There is a recommendation level of I, meaning there just isn't enough data to make a decision. And personally, I think if they really want to do service and they don't want to look at things properly or there's a lack of evidence, then just say that. There's no data out there. Every time they put a recommendation out for these self-exams. They say there is no new data. So it all goes back to 1996, where they said, nah.
Yeah, I was just thinking as you're sharing this that it would be great, and this would be more of Colin's field, working in the mental health field, if the mental health providers did a study on measuring the anxiety levels for self-examination. I can't talk. Self-examination. Yeah, what do you think about that, Colin? You want to pioneer this research?
I imagine that with any like self-examination, there's going to be a level of anxiety there. Just that worry that arises with the possibility of a lump or a irregularity. I'm sure that would be something that could be perhaps coupled with like the stress screening that is common with the Commission on Cancer, having that opportunity to talk with someone who's been newly diagnosed.
Yeah, they could collect the data from the screens. Yeah. I just think if you're never checking yourself, then all of a sudden you're like, wow, I'm looking really swollen down there. What's happening? And it's like too late.
I think that's where we as the Testicular Cancer Society play a huge role. So someone notices an irregularity, they can get a hold of this. They can ask us questions. We give them answers that they need. It's not just a web page that says we feel a lump, it could be cancer, and scare them. Give them perspective that there's a lot of things that can be happening acutely in the scrotum. Obviously, if it is cancer, then sooner the better to get it checked out, and provide them the support. You think a cancer organization probably does work from the day of diagnosis until the end of treatment. But then, no, we go through survivorship, but we also are there for the healthy and concerned patients.
Yeah, and I guess there is some truth to no matter whatever is happening, if anything's happening down there and you go to the doctor, a lot of people go into like black and white thinking, oh, they're going to say it's cancer. And sometimes the doctors have seen everything. So they're like, oh, no, that's something totally different. Or that's just normal.
Yeah, and we'll say, if anything, it's going to bring you peace of mind. You notice an irregularity. It doesn't sound normal. It could be absolutely nothing. But if anything, it'll give you peace of mind to go speak to your physician about it, get checked out. That worry, I think, causes a lot of stress. The unknown can sometimes be the scariest.
Yeah, absolutely. I think, the unknown, that's the scariest part, I think, of being diagnosed with cancer, not knowing what's going on. Or even before that, before I was diagnosed, I was pretty afraid because I was like, what's going on? I'm tired all the time. And then actually, I felt a sense of relief when I was diagnosed because I was like, well, at least now I know what's up.
My story was probably the ultimate relief. So I had felt a lump, and one of the reasons I started the Testicular Cancer Society is because as a clinical pharmacist, I knew testicular cancer existed, but that was about it. I felt a lump. I remained silent. I went back to my hometown and threw a big party and figured it was Thanksgiving weekend and figured in a couple of months that everybody would find out that I was dying from metastatic testis cancer. I ended up continuing to stay silent all the way for 7 months. I made peace that I was going to die from the disease, realized how great my life had been. I had been surrounded by friends. I had been a pharmacist at 22. I used to play around the country or go around the country playing soccer. Like, I didn't have a whole bunch of complaints. There's others that had a lot worse life. I was single. I didn't have any kids. I only had to worry about myself. It was like hey, I'm going to take one for the team type situation. And when the doctor was like, I'm going to give you the best care, and I said, I'm not going to die. He said, no. And I asked him, my immediate response was, can I get some money back? Because during those 7 months, I'd been living like I was dying. And so it was a sense of relief of, one, I ended up with stage 1 disease miraculously. And then the second of it was almost that, see, I knew I was right. I do have cancer, which is, again, just a weird aspect. I don't know. So I probably shouldn't be analyzed.
So there was that sense that you wanted a do-over, but then maybe a self-fulfilling prophecy there that you're like, yes, I was right.
Yeah, see, I'm right. And then, of course, what really drove me is I really can't just suddenly pass away one day and my parents find out that I thought I had cancer and didn't do anything, they did pay for my college tuition, and I think they'd be wanting some money back. Why is my son so stupid?
Yeah. And on this topic, thought maybe you could let us know a little bit more about what ballchecker.com is.
Yeah, so it started years ago. We used to have brochures on testicular cancer, right? Everybody's going to have a brochure on it. And we also had made little cards. They were like business cards. And on the back of it, it just showed you how to do a self exam. And if you notice any irregularities, you call your doctor. And there was a nurse, I believe it was Rutgers University, that was tabling at university, a nursing student. And she got back in touch with me and she said, it's so funny because these young male students would come up to the table and no one would touch the brochures, but they would sneak one of the business cards and stick it in their pocket. And I'm like, yeah, I guess that kind of makes sense. And so a little bit later, there was a thing called the Southwest Ohio Give Camp, and it was some IT people that get together over a weekend and decide they do it to help nonprofits in the area, but basically on any kind of IT issue the nonprofit might be having. And so I went to them and said, we'd like to have a mobile app that just basically gives a couple of facts about testicular cancer, gives instructions on how to do a self-exam, and then also how to get a hold of us if they notice anything wrong. And so they built the app over the weekend. We've had it redone once, and we're actually in the process of having it redone again because it's been some years and it's a little antiquated today. Maybe we'll see Monday if the new one's ready, but it's as simple as that. But then the thought was, how do you get individuals to download the app? And we've given lectures at high schools and awareness talks, and everybody has a phone. If we tell them, hey, go to testicularcancer.org/how to examine your testicle mobile application for free, no one's going to do it. And so we thought, what about ballchecker.com? And that's exactly it. We would lecture in high schools and at the end be like, all right, we're done. There's a few minutes before the next class. If anyone's allowed to take out their phone, as long as they go to ballchecker.com. And of course, there's Snickers trying to get the attention of younger individuals, and the app gets downloaded. So basically, that's the gist of the ball checker.
So you came in like a wrecking ball.
Yeah, sometimes you got to figure out one of the biggest challenges, and I guess this is an aside, but one of the biggest challenges in raising awareness for testicular cancer is getting access to the people that need to hear it. And how do you do that? I'm a little bit older, luckily. I'm almost an 18-year testicular cancer survivor. But nonprofits used to be, my thought growing up, is you're licking envelopes and sticking pamphlets in it and mailing it to people's houses. And that just doesn't occur anymore. So then you figure out, how can we get in the schools to educate with their health class? And I looked quite a few years ago, and in the state of Ohio, for example, I think there was 975 high schools. I'm like, gee, we'd have to go to 3 a day just to be able to educate all the students. And that's really, we don't have the capacity for that. On top of it, when you go to a school and say, hey, we want to come in and talk about testicular cancer, I've not had one that's been really excited for it and receptive. And so we thought, if we can't get to the people that need to hear it, how do we get to where they are? That makes sense. So if they're on their phone, we can get the information into their pocket, not via that business card, but with a mobile app, and then some clever and different marketing to get that download to occur.
This website is wonderful that you have. I think it's really great. And it has everything you need to know, like self-exam, how to, you've got even a video here. Check yourself before you wreck yourself.
That might be the one that you're seeing in partnership with Manscaped, one of our biggest corporate partners.
Yeah, I was like, I saw them there, Manscaped, and I was like, I feel like they have all the shaving products, right?
Yeah. They used to say below the belt grooming, and they really have an array of products. But it was a partnership I don't know how you can make a better one, to be quite honest.
Yeah, they're directly related. A lot of people are using Manscaped. So
Well,
I'm
not just
curious.
that, but they have a similar target audience. They have a lot more marketing prowess than we certainly do. We know the disease, but we don't necessarily know how to reach everyone. And
Yeah.
they've been incredible. We would work all year long years ago to get 1 million social media impressions. And then Manscaped comes along, and we just put in for won some Shorty Awards, which is it's awards for advertising and marketing, that kind of stuff. One campaign we did with them reached 124 million people.
Wow.
That's incredible. And we never, again, would have had that capacity or the ability to really reach them. And so they've been tremendous in helping us raise that awareness and really end up saving lives through early detection.
And no more schools, right?
No, we're working on some things in a little different capacity at the moment. There are some states, interesting, when we would go into schools a lot, it was in Connecticut with the breast cancer organization. And it got to the point, there was a couple of big schools where they said, you're coming in and you're taking half the class over and talking about breast cancer, but we don't have anything to do with the guys. And so that's what we originally teamed up with. And there was a lady up there that was able to get legislation introduced. And a couple of years ago, Connecticut mandated that there has to be self-examination teachings in the high school level.
Oh, interesting.
Yeah. And there are some other states it's hard to find, like, where is this? Is it in the curriculum requirements or this or that? But so we have some things we're working on right now that would allow students or teachers to either use as a tool in the classroom or to assign as homework, even sports coaches to be able to say, hey, I want you to know about testicular cancer. I think one of the challenges is those coaches don't feel like they're an expert in the disease. They really don't want to talk about it. They want their kids to know, perhaps, but they don't want to be the one talking about it. And so this would allow them to say, hey, this is what you need to do, and then bring back proof that you did it, and then you'll get a chance to play on Saturday. At least that's what we'd hope. But if not, then you're going to be sitting on the bench.
Yeah, that would be really great. And I think ninth grade is when they have that health class where they talk about sexual activity and all like the different organs that people have. That would be another place to have it. So it's like having it in two different places.
Yeah. And unfortunately, there's still some taboo about testicular cancer, much of the way we saw breast cancer 30, 40 years ago. No one's really talking about it. A good litmus test, I always say, is if you ever had a conversation about testicular cancer at work with a coworker, and not very many people say yes. Now, you'll talk about breast cancer or cervical cancer or lung cancer, all this stuff, and if it is testicular cancer, is it because it was some kind of joke or a snicker? So there's still a lot of work to be done as far as normalizing those conversations. And so I think it is still a difficult subject matter. Again, for someone, if you're a baseball coach, there's a college baseball coach in Michigan. He tells all his players about it. He incorporates testicular cancer awareness into like their annual golf outing as a fundraiser, hugely supportive. But most coaches aren't going to have that experience. Thankfully, we wish no one would get testicular cancer. But if there was a tool to be able to give to that coach to say, hey guys, this is important. Go home, learn about it. Come back and prove to me that you did it. That's all they have to do. It's like just saying, hey, go to ballchecker.com.
Yeah.
That's simple. Yeah. You don't have to be an expert. You don't have to know that it's the leading cause of cancer in adolescent and young adults. You don't need to know survival rates or treatments or anything else. You just need to be able to say something simple. I want everyone to go to ballchecker.com, download the app.
Yeah, and also sounds like when I saw that URL, I was like, I wonder if it's like some sort of like basketball company where you like check out the balls to make sure that they bounce correctly.
When you're in the middle of an IT speed weekend, I can't think of the right term, but you show up at 5:00 on Friday, and at 1:00 on Sunday, you got to present your final pattern. And so at 3:00 in the morning, what do you want to call this? Ball checker seemed reasonable since we're doing an app for self-examinations.
Yeah, no, it's a great name. So everything is very comprehensive on the website, but for our listeners, I was hoping you could share a little bit of what you recommend for self screens.
Yeah, again, there is no perfect science or anything else. We recommend that you do a self examination once a month. One, it's a routine. Is 30 days the best? Is 14 days the best? Is 60? There is no answer there. But the important thing is that you're on a routinely basis, examining yourself and looking for any kind of changes. One of the biggest things up front is just becoming familiar with yourself. It sounds a little weird. Not everybody has really rolled their testicle between their fingers and thumbs, felt the epididymis, knowing what that is. And it's not just testicular cancers. There's something else that they've noticed. So we just say do it on a monthly basis. That way you're used to it. Pick a day, the first or your birthday. Mine's the 20th. So every 20th of the month, I can do a self-examination. Becoming familiar with yourself. And then that way, if you're checking every day, you also don't notice any little tiny changes. It's like someone, to oversimplify it, let's say that has weight gain or weight loss. If you see them every day, you might not notice that over a period of months, they've gained 15 pounds or lost 15 pounds. But if you saw them at first of the month and then the first of the next month, you'd notice that more dramatic difference. So 30 days seems reasonable also to allow to notice any small changes, and the cumulative where you might not notice it every single day.
Yeah, it's great also to increase the self-awareness of the body. There's so many cases out there where people just had no idea that cancer was, that they had cancer. They noticed changes, but they didn't really pay attention to them.
It's unfortunate, and it's not just one isolated case. There's been several over the years of individuals, young individuals too, which makes it more difficult. I think what people don't realize is testicular cancer, when someone passes away from testicular cancer, it's the largest number of life years lost of any cancer outside of pediatric cancer. So when someone passes away, they're losing decades of life. And likewise, when they're diagnosed and successfully treated, they're facing decades of survivorship. But these individuals being diagnosed post-mortem. There was a student at the University of Maryland that comes to mind that the story absolutely devastated me. Didn't feel well, went to campus health, got back on the bus to come back to his place, and suddenly just dropped on the bus. And post-mortem found out that the reason he was having problems breathing wasn't because there was something going on campus or he had the flu. It was because he had tumors in his lungs. And that's just really sickening to me, to be quite honest.
Yeah, I'm curious if have you heard of any cases where it started in the testicles and it left and it just metastasized, but never they were just clear down there?
So yes, there's a couple of different situations. You can have a regressed tumor in the testis. Now, let's say they find a tumor in your abdomen, normal predictive spread pattern, but they do an ultrasound of the testicle and they really can't find anything. Sometimes they can go back in if they do the orchiectomy or remove that testicle. Let's say it looked like the cancer had come from the right side of the body, so they remove the right testicle. When they go in there, they can find some evidence of scarring, which would show maybe that there was a tumor there and somehow it just spontaneously combusted, for lack of a better term, but maybe it cut off its own blood supply. But there's also situations where you can have a germ cell tumor that never originated from the testicle itself. There's situations where you can just have that suddenly the tumor starts growing in the abdomen. And then there's also what they call a primary mediastinal germ cell tumor, where the tumor, during the fetal development, there must have been a few cells left in the sternal area that suddenly malfunctioned decades later. And you can have the exact same type, like germ cell tumor, that usually you see in the testicle, but you would find in your chest. And that can occur in the brain too. Luckily, those situations are more rare. You can have these germ cell tumors in different areas of the body, typically those three, but not see them in the actual testicle itself.
Thank you for that thorough response to that. I actually was misdiagnosed with testicular and was treated like I had testicular. But then actually, after all my treatment was done, they decided, oh, this is actually mediastinum.
Really?
Yeah.
Yeah. And I had no idea until we talked. I don't even know that I knew you had germ cell tumor. Yeah. We had a situation several years ago where patient presents to the emergency room and having chest discomfort, and they see a tumor. And so they do all the cool C's and all that kind of stuff that they do and wanted to do and send them home. And I talked to the mom and I said, did they do an ultrasound of the testicle? And she said, no. And here, yes, they found the tumor in the chest, but it actually had come from the testicle. Or there's other cases where they'll work up thinking like what you had as a thioma or anything else, but never think, man, you probably could have just pulled tumor markers and known that the patient had a primary mediastinal germ cell tumor. And that's something you want to act on sooner than later because it is a little bit different biology as far as the treatments aren't as simple.
Yeah, actually, the marker I think they used was, I think that it was called like HCG. And they said it was like off the charts. Like, they were like, yeah, usually we see these levels in pregnant women.
Yeah, the beta HCG, and it's exactly not all testicular cancers secrete them. There are ones that do. So it's not an effective screening tool, unfortunately. Of course, there's a lot of internet rumors that it is, but we certainly would never suggest doing it. But those levels are typically between 0 and 5 in most males, and they can get exceedingly high. We've had someone new will get diagnosed and they'll think my level is supposed to be 0 to 5 and it's 100. And oh my gosh, it's horrible. And then we can simply give them perspective and say, we've had patients with beta HCG over 2 million and have had successful outcomes. So yes, your 100's a little high, but you're nowhere near the record. Let's relax and just get this taken care of. We'll be fine.
And I think that's been what you were referring to as like the seed and soil theory. There's that ability to have that mesocyst, and it may not necessarily be present in the organ or the soil, as it's kind of referred to in that theory. I know that we've spent quite a bit of time on screening and self-examination, but wanted to see if you could also just speak to maybe some novel treatments of testicular cancer. For one, you had mentioned is it the orchiectomy? Did I pronounce that correctly?
Orchiectomy? Yeah.
I was so close.
It's barely off. And in the UK, I think they say instead of orchiectomy, no matter what you call it, essentially what it is a surgical procedure to remove the testicle that's affected by the cancer. Interestingly, and I had no idea at the time, actually, I remember being a pharmacy intern and looking at the OR schedule and seeing orchiectomy on there, and I didn't know what it was. And so I looked it up, and it's removal of one or both testicles. I was like, man, I would hate to have to do that. I'm a 22-year-old pharmacy intern, not knowing, guess what, buddy, you're going to have it done to you years later or 10 years later. Anyway, they removed the testicle actually from an incision high in the groin, much you'd have for an inguinal hernia operation. They don't actually touch the scrotum or anything like that. So that's really the first procedure. If you have an ultrasound and it looks like it could be testicular cancer, then they remove the testicle itself. They don't biopsy it. They have to assume that it is testicular cancer unless pathology somehow proves otherwise. That's the original procedure. And then from there, depending on where the cancer is spread to and what your tumor markers are, and then what that pathology is, really gives you the staging needed to figure out, okay, then what's the treatments from that stage. There is a more major surgery called a retroperitoneal lymph node dissection where the lymph nodes in the abdomen are removed to control the abdomen from any kind of spread. The good thing we know, testicular cancer spreads in a very predictable pattern. That's why we've had such success rates in treating it. The year I was born, if you had metastatic testicular cancer, your chance of surviving 5 years was 5%. The year I was diagnosed, the overall survival rate was 95%, completely flipped all within really 30 years because we know how the disease spreads, effective chemotherapy, and the likes. The retroperitoneal lymph node dissection, for example, typically was used on one type of testicular cancer. There's recent research led by a great surgeon out of the University of South California that shows that same procedure can be done in the other type of testicular cancer and have successful rates while maintaining that patients aren't having to receive chemotherapy. There's also some new biomarkers coming out to try to discern if it's testicular cancer or not that are promising as far as looking better than the traditional tumor markers we use. You mentioned the beta HCG. There's also situations where beta HCG can be elevated, but it's not because of testicular cancer. It can be a false elevation. Now, that could be laboratory interference, which can occur sometimes. It also can be in patients that use cannabis, or it could be in patients that have low testosterone. You would hate to confuse a patient that may have been diagnosed with testicular cancer, but 3 years down the road, the beta HCG goes up because they might be using cannabis and think, oh no, the cancer's come back, we need to do something. Hopefully these new markers will help better identify things in that situation as well.
Mike, just to maybe wrap up, I wanted to ask if you could speak to that survivorship. And you had mentioned that there's just been that large advancement in the treatment of testicular cancers and resulting in a vast improvement of that survival.
Yeah, a lot of times with cancer, you hear for the cure. And when it comes to testicular cancer, don't get me wrong, there's some work, a lot of work really, that still needs to be done in understanding certain situations. The primary mediastinal germ cell tumor, for example, cases of best ways to treat advanced stage diagnosis up front or advanced relapse stages, how to treat stages that, for the cases that show resistance to chemotherapy. A lot of times we'll hear that testicular cancer is so curable, but yet 1 in 20 guys diagnosed are still dying. So there's still some work that needs to be done, obviously, for the cure. But a lot of it is also the burden of the cured. And when you're diagnosed, you go through your treatments and you have 40, 50 years of life afterwards as a survivor, and you're facing the long-term impacts of the consequences of treatment that were necessary. How can we reduce those burdens? For example, the easy thing is early diagnosis. I was diagnosed stage 1. I was able to not get chemotherapy. I was able to be monitored. Knock on wood, it hasn't come back. And so I don't face the long-term consequences of the chemotherapy. That's really what is a big challenge in testicular cancer now, is how do we reduce the burden of the cured? How do we get them with the least invasive means?
Mike, I wanted to thank you for being with us and speaking on testicular cancer. I just wanted to just ask if there's anything else you would like to share.
No, it's been great talking to you all. I appreciate everyone listening and appreciate you having us on. Certainly, if anyone in your life's been affected by testicular cancer, have questions, never hesitate to reach out to the Testicular Cancer Society, our website, society.org. We're never bothered to help in any manner that we can by anyone affected by the disease. It's also, I guess, important to recognize that testicular cancer just doesn't affect the one that receives a diagnosis. It affects everyone around that individual, from caretakers to loved ones to employers. So any way we can help, we will certainly try our best to find out how to help you.
Our podcast will discuss topics related to cancer treatment and the recovery process, including diagnosis, family support, resources, medications, and nutrition. We aspire to have conversations pertinent and relevant to the cancer journey. Thank you for listening to the Sick and Good podcast. We'd like to invite you to connect with us on our social media and Instagram and Facebook accounts. We're also happy to share that we have launched the Sick and Good podcast website, sickandgood.com. This website is a place to read our bios, subscribe to the podcast, listen to full episodes, or read full transcripts, and contact us with your questions or comments. We care about your listener experience and would love to hear from you to keep the conversation going on the topics of cancer and wellness.